Hi everyone, thanks for coming. It's definitely great to be back after a year and see so many of you that made the trek over here from Y2E2 and a few people that I haven't seen before. So so today I'm going to be talking about my dissertation. I worked on household sanitation services in Sub-Saharan Africa, and I'm going to talk about 3 chapters. One that looks at coverage targets, one that looks at child health, and one that looks at a benefit cost analysis that I did. So sanitation systems, these things include toilets, latrines, wastewater treatment plants, fecal sludge management. These have widely been considered a major public health advancement in our time. But 2.3 billion people still lack access to basic sanitation services as of 2015. Now, basic sanitation services are things that are expected to adequately protect people from exposure to fecal pathogens, things that might give you potential health problems. So it's a persistent problem that we're dealing with. Within these 2.3 billion people, 892 million people have no access to sanitation. So these are the people that you would say open defecate. So they dispose of feces in fields or with solid waste. And this is what we consider the bottom level of sanitation service, no sanitation service. So within the Sustainable Development Goals, there is a focus on sanitation for one of those goals, and that is partly to eliminate open defecation. It is also to ideally reach universal coverage of adequate and equitable sanitation. So within these sanitation goals, there's a ladder of progress that we could think about. This is at the bottom, and ideally will be eliminated by 2030. The next level up, though, is unimproved sanitation. So these are things like pit latrines without a slab. If you picture just a hole dug in the ground, a bucket latrine, which is a bucket, or something like a hanging latrine, which is shown here on the left. So it's a latrine that's over a body of water and empties directly into it. That's approximately 857 million people. Then the next level, which is something I'm going to talk about a lot today, is limited sanitation. This is an improved facility, something like a flush toilet or a high-quality latrine with a slab that's used by more than one household. So approximately 600 million people use this. And then at the very top of this household level sanitation is basic sanitation. So that's similar to limited, where it's an improved facility, but it's used by just one household. So globally, 5 billion people use that, but that's including the US, for example. So most of us have access to basic sanitation. Now, there is a level above this that focuses on safely managed, that looks at things like wastewater treatment. But for this talk today, I'm focusing really on the household level. So I'm going to focus on these 4 categories, and in particular, basic and limited. So my dissertation looks at Sub-Saharan Africa in particular. So Sub-Saharan Africa, the majority of countries in this region have achieved little or no progress between 2000 and 2015 regarding sanitation. So while there might have been a reduction in open defecation, you can see 32 to 23%. There's been a pretty substantial increase in limited sanitation. There's been increases in unimproved sanitation and increases in basic sanitation, but all of them were pretty small. And it's not quite where anyone wants to be. And so we're trying to think about how to really think within this region what these different levels mean and how we might get more towards the top of the ladder. So these international indicators, I'm sure you're thinking they're quite basic. It's just the type of infrastructure, and it leaves it at that. But that's sort of necessary at the global level. But it gets much more complicated when you think about what do they mean in the local context, and then how are we actually evaluating them. So when they thought about these indicators, they clearly thought, let's reinforce this metric. So even the World Health Organization and the UNICEF, when they stated these indicators, they reinforced that the 2030 Agenda calls on countries to set their own standards, keeping in mind these national level or international levels of ambition, but accounting for national circumstances that might be different. So that's something I'm going to talk about today, is how these indicators might vary at the local level to some degree. And then the other thing we have to think about clearly is how do we evaluate the impact. So if we're thinking that unimproved is a worse option than basic, for example, what exactly are we talking about? And so clearly sanitation facilities differ, and we have to think about what might be the effective measure of these things. So a very common one is health outcomes. And the most common of those over the recent history of sanitation research is diarrhea illness. So we would think that as you move up the sanitation ladder, you might have less diarrhea illness. And to give you an example of how this is complicated, the most recent meta-analysis on this topic found that as you move from unimproved to basic sanitation at the household level, you would have roughly a 16% decrease in diarrhea prevalence. In comparison, a couple of randomized control trials that looked at very local areas found that going to basic sanitation within an intervention trial led to 0 change in diarrhea prevalence. So you might have something that theoretically could be quite beneficial, or you might have something that doesn't have any health outcome that's measurable, at least. And so thinking about what this actually means is important. There's also other health outcomes that we consider. Child growth is a common one, where you have children that are too short, potentially, which is referred to as stunting. And so that's due to potentially prolonged exposure to pathogens and increased diarrheal illness, or you might have underweight, which is something that might be associated with more acute illness. So there's other things that we can look at that might be associated with sanitation improvements. And hopefully I'm going to make us all think a little bit more about how we actually use these different indicators to make decisions. So to go through these different topics, there's 2 main topics I'm going to talk about. One is limited sanitation versus basic sanitation. So that's the top level, which is a private improved facility, and the next level down, which is a improved facility which is shared by 2 or more households. I'm going to have another topic on community sanitation versus household sanitation as well. So the first 2 things I'll talk about is looking in particular at limited sanitation facilities and child growth in Sub-Saharan Africa. And then I'm going to look at a benefit-cost analysis of limited and basic sanitation in Kampala, Uganda. And then lastly, I'm going to try to situate this as we think about what community-level sanitation coverage might mean for child health outcomes. So let's start off with the first study. Between 2000 and 2015, there was approximately the number of people reliant on limited sanitation increased by approximately 84 million people within Sub-Saharan Africa. As you can see on the left, this breakdown between urban and rural, a large portion of that is likely in urban settings, places where there's maybe space constraints, higher population densities, and a greater need for that. But there's also a substantial portion of the rural population that relies on limited sanitation, going from 8 to 9%. So it's something that even during this period where it's not the ideal end goal for sanitation, it's grown pretty dramatically in Sub-Saharan Africa. In spite of this growth, though, the effectiveness of limited sanitation services in improving child health remains uncertain. So there's been studies that have associated limited sanitation with an increased risk of diarrhea prevalence, but there's also been studies that have found in certain settings that shared sanitation is associated with a lower risk of diarrhea prevalence compared to basic sanitation. So you get 2 opposing results depending on where you might look. And since it's been understudied, we don't know exactly which one might be correct in different settings. And on top of that, these other indicators that I talked about that might have additional information to share have not really been studied with limited sanitation. So in particular, I'm going to focus on stunting and underweight prevalence during this presentation to give you an idea of how these outcomes might differ. So to look at this topic, what I'm going to share is data from 25 different countries in Sub-Saharan Africa. So the 25 countries are sort of highlighted over there, and all the dots are the primary survey clusters that we relied on. This data is from what are known as the demographic and health surveys, which are an international data set. We just are focusing on Sub-Saharan Africa to look at this question of limited sanitation. Within this distribution of 25 countries, there's a pretty good spread of sanitation. There's people that use open defecation, unimproved, private improved, and then limited or shared improved sanitation. And as you can see right here, so what I've done is I've focused on 2 to 5 households for limited sanitation. And this is largely for one reason. So when you think about shared, there's a whole spectrum. You might be sharing with just your neighbor, or you might be sharing with everyone in town, 100 other households or something. Most of us would intuitively think that's a very different type of sharing, and I would argue that's correct. So what we're going to do is we're trying to limit to neighbor sharing, so between 2 to 5 households. This 5 household threshold is also something that was suggested during the Sustainable Development Goal discussions as a potentially adequate threshold for a reasonable number of sharing. So it's where we focus to both feed into that dialogue, but also to make sure we limit it to neighbor shared. So as I said, we're going to focus on looking at improved sanitation, and I want to talk about how child stunting prevalence and underweight prevalence is affected by a sharing sanitation compared to open defecation, unimproved sanitation, as well as private improved sanitation, which again is basic sanitation. And I also want to talk briefly about what this would look like if we thought of diarrhea as the main outcome we were considering. So to do this, I've taken the data, the household surveys from these 25 countries that I talked about, and I have put them all into a data set, and then I've taken a variety of approaches to improve the data set. What I've done is a combination of propensity score, Mahalanobis distance, and exact matching to reduce the characteristic differences between treatment and control children. So if you think of a treatment household as a household that has shared improved sanitation, and a control household is one that has open defecation, these households are inherently different on many other factors. So here are a few of the highlighted factors that were most divergent between treatment and control households. And to highlight a couple, first, this white box is the distribution of unmatched households. So in our basic population that I took from the DHS surveys, the percent private improved sanitation around a household. So thinking of that as the community coverage around a household. You get very different outcomes between the treatment household and the control household. This means that an open defecation household might be more likely to be surrounded by other open defecation households, while a household with shared improved sanitation might be much more likely to be surrounded by people that also use some level of improved sanitation. And if we think about why this is important to control for, it's because that also might have an impact on health outcomes. And if we want to understand the impact at the household level, we have to control for these other factors. Interesting, this category has been neglected in many previous studies, so it's particularly important that we control for it here. Other factors are wealth index, so the socioeconomic status of a household is often correlated with sanitation as well as health. The population density, also often indicative of what type of sanitation might house. Open defecation might be much harder in a very dense area. Also, this was often excluded from previous studies. So as we match, we get rid of these differences. We take treatment and control children, we pair them up, and we get much better balance between the two groups. So we then take this matched population, which is much more similar, treatment and control children that have similar characteristics, and then we plug those children into a regression framework. Thinking of the health outcomes, so stunting or underweight prevalence is what I'm going to share first. And then the treatment, so what type of sanitation they have. The same characteristics that we matched on, we also control for in the regression. And then we use random effects to control for each matched set. So every child is in a matched set, and we control for that to make sure that we're accounting for the matching. As I've alluded to, there's many different treatment and control comparisons. As we match, we match just within these. So we're matching open defecation to shared improved, we're matching unimproved to shared improved. So for all of these analyses, we have a slightly different sample. We're not using the same kids for everyone, we're using different kids. So the results. So when we have this match group and we do the regression, I'm going to share with you the marginal effects that we found from these logistic regressions. So these are the percentage point change in these outcomes. So these are stunting and underweight prevalence in the treatment and control groups. So one that I'm particularly interested in, open defecation to shared improved. These are the ones that I'm highlighting right now. So open defecation to shared improved for stunting prevalence, there was a benefit. So shared improved households had a reduced prevalence of stunting, 1.9% percentage points lower. Underweight, there was a similar trend. As you can see by the error bars, which these are 95% confidence intervals, it wasn't statistically significant, but it followed the similar trend suggesting a potential benefit. If we go out to this comparison of unimproved versus shared improved, there's a similar trend as well. It sort of switches on the statistical significance. A reminder, we're using different populations, matched populations for each of these analyses, but still a similar trend of potential benefits from shared sanitation. Now as it goes across, these are open defecation and private improved, unimproved and private improved, and then highlight this last one because it's particularly important for the point I'm making today. Shared improved versus private improved. So it flips now. Private improved is the treatment group and shared improved is the control group. What you find is there's essentially no difference for stunting prevalence. So whether you have at the household level a shared sanitation facility or a private sanitation facility might not affect your stunting, but you might get substantial benefits from underweight prevalence, is what the indication is. So different results, different outcomes. Why might that be? One argument is sort of I alluded to earlier. These represent different qualities. So stunting might be more of a reduction in longer-term exposure that somehow shared sanitation is reducing, or underweight, when you have a private sanitation facility, maybe the elimination of these sort of inter-household risks where you're sharing with another household and getting exposed to more pathogens might be beneficial for removing that acute illness factor. It's definitely complicated, but I think that's one of the important reasons why we need to look at these different outcomes. So to really highlight this a bit more, I want to briefly say show what diarrhea did. So diarrhea we did not focus on as a primary outcome because it has some weaknesses. It's self-reported, and so there's potential bias or just incorrect reporting from the caretaker's perspective. In the DHS, it's particularly challenging because these are large surveys. But regardless of those weaknesses, if you're focusing on diarrhea, you would get a very different understanding of limited sanitation. As I said, we would get potential benefits if we were looking at these outcomes. If we looked at diarrhea, we would think that limited sanitation only presented a risk. So diarrhea prevalence was higher for limited sanitation, even compared to open defecation in this household. As I said, that indicator has some weaknesses, but nonetheless, people have used it even within DHS-based surveys. So, and it continues these sort of inconsistencies even with unimproved sanitation. So the main takeaway from this first study is that shared sanitation has benefits over open defecation and unimproved sanitation for stunting and underweight outcomes, although it was potentially not as beneficial as private improved sanitation, particularly if you're looking at underweight. So there's a lot of factors to consider when we're determining the effectiveness with regards to health outcomes of these two different sanitation options. So now to move on to the second chapter. So the first chapter I clearly focused on health outcomes, but sanitation choices are much more complicated than just what health might be, what the health outcome might be. So what I'm going to do is present a benefit cost analysis of limited and basic sanitation in Kampala, Uganda. So I've been arguing you want local results, so this is very local. I'm looking at a specific city and thinking about what might be happening there. So within the city, in an alignment with this previous chapter, there's a few different options you might be considering. There's an initial service level, so thinking about what households might be using right now. That's open defecation or unimproved sanitation. We're thinking about these as what the local government of Kampala guaranteed wants to get households away from. They're like, we have this as a service, but we want to move on. We want to move to one of these. We want to move to private improved or some level of limited sanitation. That could be unspecified, so any level of sharing, which is what the Sustainable Development Goals are, or they could try to specify a particular level that they want to limit to. And within this, with this framework in mind, we're talking about what are the benefits and costs of different household sanitation service options within the slums of Kampala, Uganda. So focusing on this population that really struggles with these services. So the first step of this study, I went and I talked to a number of sanitation stakeholders, 26, in the government and non-governmental organizations of Kampala that were working on urban sanitation challenges. So I did this in particular to understand costs and benefits attributed to sanitation service improvements in this setting. As I said, many people, researchers might focus on health, but these stakeholders might be making decisions with very different things in mind. But at least initially they weren't. The very first thing they focused on, that the majority of them focused on, was illness reduction. So they said when you get a sanitation improvement, you get improved health outcomes. But in reality, they did list many other things that they thought were important. Dignity, time savings, security, convenience, safety, social standing, comfort. These are all things that the stakeholders reported as potentially beneficial to sanitation improvements. And these also have support within literature from people that have done household surveys and qualitative interviews with households that said this might be why they're investing in sanitation, not because of potential health improvements. On the other side of that is costs. So we think about things that might be barriers or costs, things that you have to invest in. The first thing that they talked about was space. As I talked about urban settings in Africa in particular, they're growing rapidly. There's space constraints. If you're talking about slums in particular, it can be quite dense. And so space, maybe not surprising, but it was the main thing that everyone mentioned was the main cost of sanitation. Beyond that, there's many costs of sanitation infrastructure. There's pit emptying, which is when your pit latrine fills up, you have to empty it out so you can continue to use it. There's operation and maintenance. There's capital investments, just building the latrine. And then there's marketing, training, partnerships, enforcement. These are often termed just software costs. They're sort of like the labor investment. They're what you do to get an intervention up and running. They're often hard to quantify as well. So what I did, starting to talk about costs. So sanitation costs have pretty substantial ranges out there, and I needed to collect a lot of data to figure out what was appropriate for Kampala and also figure out what that potential range was. So I used a number of sources, literature review, especially focused on local studies. One of the reasons why I chose Kampala was because there was a lot of existing studies, so I knew I would have good quality, even peer-reviewed data to base some of these estimates on. But I also used stakeholder interviews to check these values and also get primary data from NGOs as they build things. Bill of quantities, operation and maintenance records, and then also publicly available household surveys where I can see what households are reporting. And to give you an idea, I'm not going to walk through all the different things I've done with the cost data, but it's a variety of things, right? The capital investment is a one-time cost typically. You go out and you build your latrine. So that's once. It's quite expensive. On average, the primary point we used was $720 about. And then other ones, operation and maintenance, these are things that might occur every day or intermittently throughout the lifetime of the latrine. We've input them as monthly values, so an average amount of time spent on operation each month, as well as the average cost of maintenance that might come out when you look at a monthly value. And then pit emptying as well, it's something that happens every few years potentially. And so we have to think about that timeline. And the complicated thing perhaps is that all of these will probably vary with the number of households using a latrine. So it's not something that we're just looking at one household, we're thinking about how this might vary with the number of households. And then on top of that, there's a big range that we might think about. So capital investment might go from $470 all the way to $1,200. So it's a big range that we have to consider, and these are real numbers from Kampala. So it's not like it's part of a vague decision-making process. When they're considering what to build, they're thinking about how much it might cost them, and that's a range they look at. Now, the benefit side of things is quite interesting in my opinion. So I talked about health outcomes. That is what most benefit and cost analysis focus on. They focus on the potential health benefits and potentially time savings. So they draw all their benefits from those, and then they move on from there. And what I'm trying to do here is think about what the actual value is from other benefits. So as I showed in chapter 1, some of the health benefits were marginal or perhaps even negligible when you're thinking about this trade-off between basic and limited sanitation. But there's many other benefits to consider. Convenience, safety, dignity, health as well, but also many others. So what I did was I took some of this publicly available survey data from Kampala. It luckily had rent for households as well as many different household characteristics. So electricity, the building characteristics, quality, the location of the household, the type of sanitation and the number of people they shared with, as well as the size of the household. So the things that I was particularly interested in was the type of sanitation and then the size of the household. So what I then plugged it into is a regression framework, which treats this set of attributes of the household as all contributing to the value of the household. So at the end of the regression, the coefficients represent the value that might be gained from the percent of rent that is attributed to these individual characteristics. So for basic sanitation, for example, that meant that household with basic sanitation would have 24% of the rental value that they pay for that household due to the basic sanitation component. This is relative to unimproved sanitation. Limited sanitation was 16%. And I stopped there because as you went higher levels of sharing, there was no associated benefit of those. And so since there was no associated benefit in the sample, there's no point in doing a benefit cost analysis. It's theoretically a bad choice. And then the other one that I want to highlight here is the space. This is a cost, actually, if we think about a trade-off between installing a private latrine or having an additional room on your house. So you can think of people making this trade-off. And what I've tried to do is think about this as sort of the opportunity cost of building a latrine. You could think of using the extra space that way. And to give you an idea of this population, the average rent was $29. Now all this together, we move forward with the benefit cost analysis. I'm going to highlight that for this presentation, I'm focusing on an initial service level that has zero cost. This might seem a little bit odd, but plenty of stakeholders said that in certain unimproved sanitation categories, people don't really invest in operation and maintenance. They don't really empty the pit. And so zero cost is technically feasible, or technically reasonable. But also it's the more conservative approach. If we're thinking that this has cost, it's just going to cancel out with cost on this side. So if we get a feasible benefit cost ratio with zero cost on this side, then it will be even more feasible if we add cost on this side. So the first step is to do this with our primary data, our ideal data, one value for every category of cost and benefit. What do we find? We find that both are feasible options. Both benefits exceed cost for private and shared sanitation. The appropriate step with this is to then think about the incremental benefit cost ratio. So what would it be if you were thinking about the comparison of basic to limited sanitation? And what we find is an incremental benefit cost ratio of 1.05. So as I said at the top, it marginally favors basic sanitation, but really the differences are quite small. And so they both seem to be quite feasible options at this primary level of data. Of course, the next thing that we would do with this benefit cost analysis is to look at how all these ranges that I talked about actually affect what we would find. So we're both uncertain about the actual value of certain things, but we also want to recognize that in slums, you get a whole range of costs and benefits. There's no true value for all households. So on this graph, this dark solid line is that primary value I just presented, so 1.53 for basic and 1.98 for limited. And then 1 is this threshold of benefits equal cost, and below that you become cost greater than benefits. And so thinking about how all these different variables might affect that, there's a couple of things I want to highlight. The benefit is important. That's not surprising for us. I drew all of my benefits from that hedonic regression, looking at the value of rent and getting a rent-based valuation for the benefits. And so it's just important. And it also has a pretty wide range because I was using a small local data set to estimate it. And so you do get benefit cost ranges that go below if I'm thinking that at the very base you have a low level of benefits. Also important is lifespan. So how long are we assuming this infrastructure is built for? Is it 10 years, 20 years, or 3 years? It's sort of unclear, but this is something that I don't know the answer to. But ideally, these stakeholders who are installing these latrines, households who are thinking about this, know what their investment timeline is. And so it's particularly important to highlight these ranges, because if you're making a limited sanitation investment, it might not be that important. But if you're doing basic sanitation, you have to make sure it lasts long enough, otherwise your benefits aren't going to exceed your costs. And then also I want to highlight here diarrhea. So diarrhea, there's really nothing there. And that's because in light of these other benefits and costs, in this analysis with using the data from Chapter 1, it wasn't a very impactful benefit at the household level. And the last step I want to talk about is if you took all of these ranges for these data up here and you put them into a large model that you could draw different samples from called a Monte Carlo simulation, what you would find is that of all of those potential combinations, you would get 65.9% benefit cost ratios greater than 1 for basic, and you would get 79.2 greater than 1 for limited sanitation. So it sort of reinforces that like the majority of the time for both of these options, you're getting a positive outcome, benefits greater than results. But it's clearly more complicated if you want to figure options between these two. But what I sort of like to think about when I think about the complicated nature of it is that in Kampala, for example, they want to figure out whether or not they should be investing in both options. Sort of limited sanitation hasn't gone away, and they're investing in it currently, but they want to know like what's a reasonable and feasible threshold. They're not worried about should we do all private because they don't think that's possible. And so highlighting the fact that the health and non-health benefits potentially indicate a role for both limited and basic sanitation services in achieving adequate sanitation is something that I think is a valuable lesson to these stakeholders. And in particular, you can think about the fact that I noted that higher levels of sharing were not beneficial. So that's even more valuable. It's being like, as you guys invest, as stakeholders invest in potentially communal sanitation, which has 20 households, they might not be getting much benefit from that, but it's still a very expensive investment. And so we're using this data to inform those decisions. So talking about this community, the limited and basic might feed into this community coverage and overall reduction of open defecation. I think it's good to now talk about what this community sanitation actually means. And I'm going to talk about it with regards to child health outcomes in rural Mali. So I had a unique data set for this portion of my dissertation that was a cross-sectional data set that included census level data from household surveys in rural Mali. So we had 121 villages, and I was able to know whether or not every household in all of those villages had a latrine or not, which is a hard data set to come by. So what I did was I took these villages and defined communities within them. We didn't use the actual village as the community because a village is sort of a random area. It doesn't necessarily mean anything except for maybe politically or culturally maybe. But so what I did was I did 200 meters. So this is an area where there's some evidence that people spend a lot of time within 200 meters. I also did 500 meters and a kilometer to test. But I asked this question: are child health outcomes in the primary household more strongly associated with the community sanitation coverage or the primary household sanitation? So if you have this household in the middle of the community that's defined by this household, there's many households around. Some have no sanitation, some have a latrine. And what is most important, do we think? I answered this just with a regression model. So I took the data from the primary household. I took the data of the surrounding community. I also interacted these two terms. So theoretically, we might think that a household sanitation might be mediated by the community level sanitation. So at a high level of coverage, maybe sanitation at the household level is more effective, or maybe it's not effective, maybe it doesn't actually contribute anything additionally. And so we wanted to answer that. And so I'm just to keep things simple, I'm just going to give one of the health outcomes that we looked at here, and this is stunting prevalence. So it's something that I looked at in chapter 1 as well. And to think about how this goes. So this is the stunting prevalence in the community and for the households, and this is the latrine coverage. So all the way from 0 to 100%. And just to qualitatively discuss this figure, so at 0%, there's a bigger difference here. So on the top, you have a household who doesn't own a latrine, and on the bottom, you have a household who owns a latrine. This was not like a statistically significant effect, but you can see that this gradually decreases over the course. So at the end, you maybe don't get that much even qualitative result from having your own latrine. But statistically, and magnitude-wise, if you consider the scale of community sanitation, latrine coverage in the community was more strongly associated with child growth outcomes than whether that household had or did not have a latrine. And with stunting, there was evidence that this went all the way from 0 to 100%. With other outcomes, underweight prevalence, for example, there was an indication of a threshold where you saw sort of a decrease up to 60%, and then it's sort of leveled out. But either way, there's this indication that community level coverage is important. It's something that needs to be considered both when we're designing and deciding policies, but also when we're evaluating household sanitation infrastructure. Fortunately, data is increasing. We can perhaps do this a bit more, but it's something that is continuing to need a little bit more investigation. So that was a very brief overview of my third chapter, but nonetheless, I would think about how we can put this all into, sum it up. So thinking again about Sub-Saharan Africa. So household sanitation services have remained inadequate throughout Sub-Saharan Africa, but efforts towards universal coverage can likely be improved. We have this complicated international framework and local decision-making. But I think some of the lessons from this dissertation can be beneficial when we think about how local settings might really focus their progress and improve sanitation. So first, starting with what I just ended with, let's recognize the potential for limited sanitation contribute to overall coverage. So the fact that we found potential benefits at the household level, both health and non-health, makes the argument that limited sanitation is a feasible option and not one that should be discounted. And in light of what I just presented, which I'm reminding you of right here, the importance of community coverage, perhaps then limited sanitation is a more important component for this community coverage than we've maybe given credit to before. And on some level, you might think, I haven't been able to investigate this, but on some level you might think that this marginal potential risk of health between limited and basic sanitation to some degree might be discounted if you consider the overall progress towards community coverage. So if you reach 100% coverage, even if it's limited and basic, you might get overall improved health outcomes. The second is to consider value and motivations for household investments beyond public health, and particularly diarrheal illness. So much focus on one health outcome it can clearly set you up for misleading evidence. Many studies, especially well-designed randomized control trials, often use many outcomes to make an argument. But at the same time, many observational studies still rely on single outcomes, and even though there's more there. And even beyond that, like if I was just focusing on health outcomes, we might miss the benefit to individual households. So these households were perceiving a benefit that was apart from health, most likely. They were perceiving a benefit that was due to these other factors that I talked about. And it's important to them, and it's important to the government and non-governmental stakeholders. And so that is something that is logically could be included in a benefit cost analysis when you're making these decisions. And then last, think about placing these potential cost savings of limited sanitation in the context of potentially reduced benefits. I hinted at this earlier, but in Kampala, for example, they are investing a lot into large shared facilities. So facilities that are communal in nature, that are public in nature, and might have 20 households using it or even more. And it's because they can find space for these things, and it's something easier from the government perspective potentially to manage. But at the same time, if there's no perceived benefit from the user perspective, then it might be much better to think about spending a little bit more money and thinking about other ways to invest in smaller levels of shared sanitation where you're actually getting a benefit. And this, of course, can have multiple outcomes where people continue to use the facilities if they perceive benefits, versus if there's no benefit, they might resort back to open defecation. So overall, this is clearly a map of the world. And as you can see, Sub-Saharan Africa is one of the places that has struggled the most on these international indicators. And international indicators are great. Like, I've relied on them a lot in my research, thinking about these easy categories to investigate. But local governments and organizations face a lot of challenges when they're making these decisions and trying to make effective decisions at a local scale. And so thinking about these alternative ways to use cross-sectional data or observational data to better inform these local decisions and give governments and non-governmental organizations more information to make at a local scale, I think is very important and will improve sanitation overall. That is it. Thank you. So I'm happy to take questions. I think it looks like we have like 10 minutes. Sammy.
Did you show local government officials your like alternative valuation of the benefits of the latrines, and what did they say?
No, that's one of my like, I think would be interesting to do. I think it's, like I said, it's in the interviews they clearly like agree on some level. Like there's illness benefits they think, but they also think about all these other benefits. But one of the biggest struggles with sanitation is that it's hard to quantify. There's the approach that I took, which uses this publicly available data. There's also, you can do very in-depth like contingent valuation studies where you're asking people what they're willing to pay. But the problem, it's hard to quantify. And so these people don't have an intuition for what these values actually are. And so I think they would be quite interested. I'm not sure how they would respond.
And do people's willingness to say correspond to some extent, or do you perceive them to correspond to what you found?
I mean, it's an interesting question. There have been studies in Kampala that have looked at willingness to pay for private sanitation, not for limited sanitation, and it's clearly a value that would vary from location to location. So it's hard to compare our study in Kampala slums to a study in Ghana. But there is a willingness to pay for sanitation, and it's hard to ground truth that with a global data set or something. I will say though that as far as like how people would respond, I think like the government often thinks on a bigger scale than households. So I think they think of the externalities of sanitation a bit more and what might come into play. But like I said, that's kind of hard to evaluate. And when we do, like the diarrheal illness is still even much smaller than the benefits of rent. So.
I'm wondering, you touched on it a little bit just at the end when you were concluding with the differences between actually using the different sanitation services and the urban one, or having access to a community.
Yeah.
I was wondering if you could talk about that a little bit more, especially how it relates to your first and third chapters with people are activity, like how they're looking for still
Yeah.
And then both sides.
Yeah.
It's sort of how urban rural divisions might affect the sort of different scales of limited or shared sanitation. In a dense urban area, sharing with another household might lead to a much worse outcome. For your sanitation access versus in a rural area where other just sparse. And it sounds like something.
So the first one, I like to think of the benefit of using cross-sectional data is that, so like for chapter 3, when we're talking about the value of sanitation, these are households that have theoretically chosen, people are valuing sanitation access at this amount, and that reflects whether or not they're using that sanitation. And so I don't have data as to whether or not they are or not, but nonetheless, the perceived benefit implies that many of these shared latrines at the low level are actually being used. In the community sanitation one, we had like data from study households, not census households, from study households that reported the level of open defecation even with households. And you get a lot more, in Mali it was unique because you had a high usage rate. Pretty much everyone that had a latrine used it, except for little kids. And that's pretty consistent across settings, is that little kids don't use latrines. For urban rural. For the benefit cost analysis, I looked at Kampala and then I expanded to include all urban settings in Uganda. So it's not urban versus rural, but it looks at how, Kampala is the most dense. So as you expand out, you get less dense and more options potentially. And so as you moved out into more general urban settings, there was a perceived value for higher levels of shared sanitation that wasn't there in Kampala. So definitely could be a difference. The evidence on how it sort of might vary overall. Is I didn't collect, but there's studies out there that look at, who are you sharing with? What is the actual management arrangement? And I think it more so varies from setting to setting versus urban to rural. There's like an odd result is that in one study they reported that urban sanitation was more likely to be shared with people you knew versus in rural, and I can't imagine that's true everywhere, but in their report it was. But in certain slums, you'd have all transient populations who most likely are sharing with strangers, and that would clearly affect the management structure, the cleanliness, and the potential prolonged use of that facility.
Great presentation, very solid topic. Well, I don't know if this question is totally related with your data and what you saw, but what are you thinking about, like, this is communities where you have the state or international agencies or other organizations like investing in the development of this infrastructure, and like the creation of this kind of incentive or culture that people start to assume that this is a service that should be provided by others. And in that sense, even created like this disincentive for people that, or a speculation of people that maybe have the capacity to invest in better infrastructure, but will not do that because they are speculating that somebody else is going to come and invest. Do you see that there is an issue over there?
It's something I've read a lot about over the years, but not something I studied in particular. Excuse me. It does create challenges. So in Uganda, there's a lot of non-governmental organizations. So not even talking about what a government might invest, but there's a lot of non-governmental organizations who've gone in and installed latrines. Many of them are, community level latrines that are shared and set up. And it results in sort of mixed outcomes. It depends a lot on the NGO and what their long-term plan is, and it depends on the relationship with the community. There's plenty that have gone and installed and have been abandoned, and then people don't feel like, there's multiple factors. Maybe they don't feel like they need to invest in it because someone else will come back and help, or they weren't properly involved in the beginning. They don't know how to maintain something that they didn't build. It's a challenging concept. In Uganda, they have a policy technically from the government level that the household's responsible, and so the government tries to limit sort of what is given out or provided, and so ideally, therefore, households would be more aware of what they're willing to pay and invest. But yeah, I don't know. The more I've thought about it, the more I like to think just of the individual responsibilities, the long-term maintenance of a latrine is just how much you value it, not whether someone else is installing it or not. There was a study in Bangladesh that was done recently that they provided all the cleaning supplies, they provided educational interventions for limited sanitation, so shared facilities, and it was these technically interventions where they were providing these different things, but it in the long term increased the cleanliness, it increased the usability of the latrines, and so maybe that was provided, but it still increased the education and awareness, and it allowed people to more adequately care for the facility that they already had access to and were using. So I think overall it's just really complicated, and I think it's more than feasible for governments to invest in it, but if households are willing to, it should be taken advantage of. Yeah.
Did you look at all the latrines that you have to pay to use? And also, was there a gender difference in who was using what kind of facilities?
Yeah, I can only briefly give brief information on that. So there was definitely lots of paid latrines, and it varied from whether they were government or NGOs or communities that operated them. From what I know, there was not really a big difference. So in Kampala, there's a policy that they have, if they're communal that you have to pay for, they sort of have to have multiple stalls, male and female, they have to be accessible which increases the cost a lot, but it sort of takes away potentially the risk that only men are using it or only women are using it. They also are all free for children, essentially. So it's the bigger factor was whether or not they were accessible to anyone. So if they were poorly located or if they were locked at night, then clearly that was more important than a fee structure. Fee structures in Kampala were competitively, they were constantly pushed down. So when a new NGO built a latrine, they wanted to offer it for free, and so other people, if they wanted to have a latrine, they had to lower their price to like 200 shillings or something, and let kids visit for free. So at least from the limited experience I had in that setting, it was overall not that was not one of the main struggles of the operation, but it also is hard because I talked to stakeholders, and I think they were forthcoming on the topics of costs and benefits and those things, but I think they often want to present their best face if they're talking to someone about how they run their latrine and what people use it. Is there another question? Otherwise, I can acknowledge the people who helped me out. Is that okay? All right. So I've been involved with the same committee for, as Buzz said, since 2013, essentially. So my two lead advisors are Eran and Buzz. They've been very nice to meet with me for 6 years now, and Eran first through a class and Buzz from the week before school started, and talk about all the different things I need to be thinking about. They were great with Eran with statistics, as well as thinking about big picture things and providing additional resources when they were needed and pushing me in the right direction. And Buzz constantly kept me thinking about why I was doing what I was doing and reflecting and making progress, and it was all much appreciated. My other two committee members are unique to me because I've known them for 10 years. So Jenna and Amy, I met them both in Tanzania, worked with them, and I've been very grateful for the years that they've invested in me. And then Beth, thank you so much. This would not have been possible if Beth didn't show up. And she showed up at the last minute, so it is very much appreciated. I was fortunate to receive funding from many different sources. I don't need to read them out. They're all there, and I'm very grateful for the flexibility and time that they've allowed me. I also had other faculty who were very welcoming to me over the years. So Nicole, thank you. And then Mike, you might not know him, but he's, in my opinion, very talented at statistics. And he was very patient, as I often was wrong. So he was very helpful on my matching analysis in particular. And then Steve also was very welcoming and letting me crash his group meetings occasionally and talk about random research ideas. I did spend time in Uganda, and people at the local university and government were more than welcoming to me and showing me around and spending sometimes hours talking to me. And then I've been here for 6 years, so I've had a lot of E-IPER staff, and they've all been super helpful and nice and welcoming. Thank you. So, from what I understand, I have to now go to a closed portion. So thank you very much for coming. It was great to see you all.